So hi everyone, I'm Alexandra Wolfe. I'm an orthopedic PA in the Boston area. What we're going to talk about, if everyone thinks, right, think about an aging hip. What do you think about? Hip replacement. I don't want to talk about hip replacement, I talk about it every single day. So the theme of my talk today is it's not always arthritis. Very commonly, patients come into my office and their chief complaint, what's on my schedule, what they think they're talking about, is hip replacement consult. Well, in my female patients over the age of 55, more often than not, we're actually talking about a problem that is outside of the hip joint. I'm sure everyone here has probably heard the term bursitis. And if you've seen me in the office, you've already gotten my spiel that I really don't like that term because the bursa is not always to blame. So some basic hip anatomy. The hip is a ball and socket joint. It's located right in the groin, so deep that you cannot palpate it. When I ask people, okay, where's the pain or where's your hip? A lot of people will first go to the waist, that bone that you can feel. That's actually the ASIS, which is a portion of the pelvis. Then they'll go to the bony bump right on the side of the hip. Wrong again. That's the greater trochanter, which is a bony prominence on the femur. That's actually where we're going to focus today, because it's extremely important for women's health, especially orthopedic health, that we take care of this peritrochanteric area. What is the peritrochanteric area? It's a mouthful for one, but it's the greater trochanter, so that bony prominence, in combination with the abductors, which are the gluteus medius and minimus muscles and tendons. Those are muscles that wrap around from the low back and insert right onto that bony bump. In addition, there is a bursa sac. There's several. Not usually the problem causers, but a bursa is just a fluid-filled sac that helps to facilitate movement and protect joints. All of our joints have them. On top of that bursa sac runs the IT band, which is a thick band of fibrous tissue that goes from the pelvis down the lateral side of the thigh into the lateral knee. All of those structures need to work in tandem together to enable us to do a lot of things. Walking, for one of them. As the name suggests, the abductors are also responsible for moving the leg away from the body, abduction. More importantly, I would argue, they're essential for pelvic stabilization. When you watch someone walk in the grocery store, and now you're all going to do this afterwards, if you see them kind of bobble back and forth, right? Most often what we're dealing with is abductor dysfunction, or an injury to those muscles and tendons. That's on a spectrum. So you can have a true bursitis, where the bursa sac is simply inflamed and it's overfilled with fluid and it's pain on the side of the hip. More commonly, we're dealing with the abductor tendons, either inflammation in the tendons, where there's angry tendons but really no structural issue. You can have partial thickness tearing, where those tendons are angry, but now some of the fibers have kind of torn away from the bone, they're frayed. Or you can have full thickness rupture, which is a fairly big problem that people don't pay much attention to. So I would argue that in orthopedics, especially lower extremity orthopedics, this hip bursitis, especially for my older female patients, is a largely ignored problem. And it's a really big problem. It impacts everything that we do day to day. So when I listen to a patient, right, they give me their spiel for the first 5-10 minutes, and then I talk on and on for a long time. What I'm hearing is, okay, my pain is over on the side of my hip. Usually they're pointing right to that bony bump. It hurts when I walk for a long time. It hurts when I walk uphill or on uneven terrain. Really hurts when I walk upstairs. Sometimes I have to do the toddler two-step, and I can't sleep on that side. Can't lay on that side. If I do, even if I fall asleep, it wakes me up. That clues me in immediately to thinking, we're talking about the abductors today. So first thing I'm going to do is torture you a little bit in the office. I'm going to poke right over that bony bump. You're going to jump. No one's going to like it. Then I'm going to rotate the hip. For external rotation, which is essentially bringing the foot up to the knee, right? That's going to cause some lateral hip pain. Next, I'm going to have you try and push that leg out against me. Either it's going to hurt or it's not going to go very far. Then I have patients stand, usually standing against a wall. I want them to stand on the good leg, and what I see is that pelvis is pretty stable. Then I have them stand on the bad leg, and what we start to see is this. And that's what you'll start to identify when people are walking in the grocery store. You can see it all around you. It's extremely common. It's called the Trendelenburg gait. It's indicative of this abductor pathology. So if we're in the office, you told me that, I felt that and made you feel that, what am I doing next? Well, I get an x-ray in everyone because you can have arthritis in combination with abductor pathology. It's very, very common. But what I'm looking for on the x-ray, a couple of things. I want to see, is there any calcification over that greater trochanter? That tells me this has been a problem for a really long time and you've probably been ignoring it. I also want to look at your bony anatomy, how you were set up from the beginning. People can be born with different levels of hip coverage. Sometimes you can have ball and socket joint with perfectly fine. Sometimes it's ball that's kind of being swallowed by the socket. And other times you can have ball that's on a golf tee where the socket's not very deep. That last one is called hip dysplasia. That means that the ball has a little bit of micromotion, right? If there's not that much coverage, that ball can move. Well, what's providing the stabilization in that case? The abductors and all the surrounding muscles for the hip. They have to work even harder than they typically do to provide stabilization to that joint. Well, live a lifetime with a dysplastic hip, those abductors are kind of tired. They're over it, right? And you've probably complained about, oh, my hip, I can't lay on that side, I have to sleep on my back, I hate sleeping on my back. And your GP might have said, oh, it's bursitis. We'll give you a shot. Oh, go do PT, right? Reasonable options to start, but not always the answer. Once I've looked at your x-ray, I've examined you, we've had a conversation, likely what I'm going to want to do is an MRI scan. An MRI scan, most of us have probably had them, pretty terrible, pretty loud. It's a static scan, so it's showing me in great detail what do those tendons look like. Are they inflamed? Is there fluid in the bursa sac? Is there some tearing? Are the tendons gone? They've ruptured, they've left the building. That clues me into what we need to do next. There we go. So, in terms of treatment options, right, we have many. My goal, and the goal of this talk, is to get you to prevent this issue in the first place, so we're not having this conversation, but I see people every single day, multiple times a day, and I'm giving this spiel. Conservatively, it could be as simple as me saying, well, don't do the things that hurt, right? Don't walk upstairs. Don't go for long walks. Don't go hiking, right? That's not super reasonable. That's not an excellent quality of life, and my goal is to get you to live your best quality of life and play pickleball, and I'll have patients tell me it's their passion sport. Well, it's hard on the abductors. They need to be strong for that. So if activity modification's not really gonna jive with us, next thing I usually step to is things like anti-inflammatories, right? We all know ibuprofen, naproxen. Some patients can't take those, right? If you have a blood thinner, if you've had bariatric surgery, if you have a sensitive stomach, not always a good option. We also have topical NSAIDs, which have been a big game changer in orthopedics over the past couple of years. Those are topical gels or ointments that go right over that bony bump. And because the abductors live so close to the skin, they can actually get right to where they need to be, and they've never messed systemically with the GI tract, which is excellent. Again, pretty basic stuff that we can do at home, stuff I don't need to tell you to be doing, but not always enough. There's also heat, right? Heating pad. Everyone thinks for orthopedic injuries, oh, something hurts, I'm gonna ice it, which is great for some things. For the abductors, not so great. What does that do? It makes the IT band tighten up, it makes the abductors tighten up, and nothing wants to work with one another. Heat is key. Heat is gonna actually stretch out those fibers of the IT band, allow things to kind of loosen up, make things like PT, stretching more effective. That brings me to physical therapy. A fantastic tool. Orthopedics and PT are like peanut butter and jelly, right? Problem for this abductor pathology and this pain is when it's in its acute stage, if I say, oh, well, just go do some PT, they're gonna start making you do, clamshells, walking with the bands, everything's going to hurt. And you're gonna come back and see me in a couple of weeks and say, that made it worse. And I'm gonna say, I know. So I don't do that. The key with physical therapy is that's our prevention tool, and that's our longer-term treatment tool to prevent recurrence. You can only strengthen muscles when the tendons are not inflamed. Otherwise, if you have an inflamed tendon, it's sending a feedback signal to the muscle that says, nope, I don't want to work. You're still doing all those exercises, so instead, all we're doing is just making the tendon more inflamed. So, We've covered some conservative stuff. Let's get a little bit more invasive. Injections. Historically in orthopedics, bursa injections were, oh, I'm gonna poke around, does it hurt there? That's where the shot's going. Great, except we don't know where it went, right? The hip is a pretty big structure, the thigh is a big structure. Who knows where that went? For abductor injections, they should always be done under ultrasound guidance. That's my opinion, I will die on that hill. The reason for that is if I want to use an injection as a diagnostic tool, right? Maybe you have some arthritis, maybe you have some abductor tendonitis. We're trying to figure out who's the chicken, who's the egg. If I can visualize that peritrochanteric space and that's where my injection goes, and you say, Alex, wow, that was 80% of my pain gone just with the numbing medicine initially. Okay, 80% of our problem's coming from the abductor. So if I was going to sign you up for a hip replacement to treat 20% of your pain, you'd be pretty unhappy post-operatively. The goal of injections is to shut down that inflammatory process, get the tendons to calm back down so that we can rehab them, can rehab the muscles, and hopefully prevent it from coming back. Injections are not always an option. They're not always a great option. We do know that steroid injections, especially repeated injections over time, can be damaging to tendons. They can actually weaken tendons. So if I didn't get an MRI scan, I didn't know there was partial thickness tearing there, and I just stuck a cortisone injection, well, now you are walking with a limp. Maybe the pain's gone, but you're walking with a limp. I could have just ruptured those tendons. So it's extremely important for us to use injections as a smart tool, not as a default tool. If there's some partial thickness tearing and we can't really do an injection, I don't think it's safe, what do? Do I sign you up for surgery? No. We have a very good technique. It's done mostly by our physiatry colleagues who are a huge benefit in the world of orthopedics. It's called a percutaneous tenotomy. Essentially, it's a funny little device that looks like a tattoo gun, and it vibrates back and forth, and it breaks up all that scarred, thickened, inflammatory tissue. It's one of the only things that we have that can prompt the tendons to actually heal themselves. They can heal that partial thickness tearing and not need surgery. But if that MRI scan comes back and I don't see a tendon attached to a bone, then we're talking surgery. And that's a pretty big deal. It's actually harder to recover from than a hip replacement. So the fact that we ignore this problem is baffling to me. Typically, that means we have to go in, grab the tendons, reattach them with anchors into the bone. That means that you can't activate those muscles for about 6 weeks, which means walker, crutches, wheelchair, limited mobility, overall quality of life decreased. My goal, even though surgeons hire me and surgeons pay me, my goal is to keep you as far away from the operating room as possible. So I need to do that by educating my patients. I talk about this every day. You guys don't think about your hips every day, hopefully. So even though surgery, it's an option, people do very well with it, how do we avoid getting to that point, right? How do we avoid having this conversation in the office? The key there is abductor strengthening. So we want to keep those muscles strong. The stronger the muscle can be, the less work the tendon has to do, because the muscle is doing the bulk of the work. The problem is, as we age, we stop playing as many sports, we stop doing as many lateral motions. Well, if the abductors are responsible for lateral motion, we stop doing them, they start to kind of shut down and atrophy a little bit. So we need targeted abductor strengthening. We also need stretching. The IT band, that thick, fibrous band, doesn't really serve much of a functional purpose except to make people miserable. So, best way to keep it at bay is stretching. And people will think, oh, well, I do stretches, every morning for 30 minutes I do my stretches. That's great. What's it doing for the, 23 and a half other hours? Tightening right back up. So there's a big misconception with stretching that it's something we just take a chunk of time, do it, and keep it moving. Well, you gotta keep it moving. So what I tell my patients is, I'm gonna give you 2 or 3 stretches. I want you to do them 2 or 3 minutes, 2 or 3 times a day. When you're watching TV, when you're making your coffee, when you're brushing your teeth, right? Easy. Keeps the IT band loose, takes some stress off of the abductors. The other thing that I really like to encourage is general mobility. Go for a walk. I don't care if it's 10 feet. Go for that walk if you can go for it. When you're in the grocery store, don't rely as heavily on the cart. Hold your own self up. Work those abductors. Keep them strong. The other thing that's really important is avoid repetitive motions. My pickleball people. It used to be CrossFit and orthopedics, now it's pickleball. That is a big demand on the abductors. It's a lot of lateral motion. I love it. I want to keep everyone in it, but you have to be prepared and you have to space out your play. That you can't overuse a muscle group and not expect it to become inflamed. Lastly, weight control. It's my least favorite topic to talk about in the office, aside from asking people to stop smoking. Two very hard conversations to have. But we do know that increased weight is increased stress on muscles and joints. So maintaining a healthy weight is really important for the hips, the knees, the ankles, the whole body in maintaining muscle mass, as well as maintaining muscle strength and general fitness. So overall, what is the point? What is the takeaway from this talk? Well, women as a whole, we deal with a lot of pain, and we grin and bear it, right? That's our whole life. We're kind of taught that, oh, that's normal. Cramps every month, go to work, you're fine. For abductor stuff, if anyone's ever saying, oh, my hip hurts, let's deal with it. If anyone's ever telling you, oh, it's just your bursitis, ask them to dig deeper. Because if we get to a place where we're just ignoring that problem, it can snowball, it can become a bigger problem. And I don't like seeing patients in the office who say, oh, I've been receiving injections for 10 years, now I walk with a limp, I can't really move too well. Well, now there's not many options for me. Those muscles have atrophied, those tendons have torn, and that's not stuff I can undo. So let's prevent it in the first place and keep people moving. Thank you.